bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Paediatric Health Centres. And today's webinar is titled Transitioning to the Future, Pediatric to Adult Healthcare Transition for Canadian Youth. All right, so we're really excited to have today's presentation, as it's a chance for us to showcase some of our own work here at CAFC and give the stage to some of our colleagues and experts from across the CAFC community that stretches across the country who have been supporting and leading this work on our behalf over the past number of years. And today we're hearing from one of our communities of practice, and in this case it's our community of practice, or COP. We might hear that referred to as the COPs later, but this is our community of practice on transitions for children to adult services. So I'm going to introduce our panel. As the panel that was listed, we have two people there. We do have a few other great experts on the panel that I'll also introduce, just so we know that they're out there in the background ready to sort of help facilitate the discussion. Behind me in my office here, we have Lisa Stromquist, who's the coordinator of our communities of practice here at the CAFC office here. We also have Dr. Gail Andrew from the Glenrose Rehab Hospital. Many of you know Dr. Andrew, who joins me as a co-host on many of our rehab webinars, but she's been a big part of the transition community of practice since its inception, I believe. And also Deborah Toole will be joining us from Alberta Children's Hospital to sort of participate in the discussion as well. Again, another participant from the community of practice. But our presenters today, first up we'll be hearing from Dr. Kush Amaria, who's a clinical psychologist in the Division of Adolescent Medicine at the Hospital for Sick Children in Toronto. In her current role, she serves as the team lead for the Good to Go transition program and works to build evidence-based practices that support the transition and empowerment of youth, both through their own development and the healthcare system. This includes leading the Adolescent Medicine's Transition Clinic at Sick Kids. We also have joining us John Greenaway, who's a social worker at Erin Oak Kids, which is Ontario's largest children's treatment centre for children and youth with a variety of disabilities. And as the transitions consultant there for the past 15 years, he's been involved in a number of regional and provincial transition initiatives, and his work has included meeting with families and youth to prepare for entry into the adult community, providing workshops focused on transition planning, as well as facilitating a youth advisory committee and a father's support group at Erin Oak Kids. So it's my pleasure to hand the podium over to Dr. Amaria. Over to you.
Thank you very much. Thank you for the introduction as well. Welcome, everybody. We're really excited to talk to you today about transitioning to the future, and we do hope you will feel like you are at the head of the game once we've kind of gone through today's presentation. So Doug did a great job of including and representing who both John and I are. So we have these day jobs, but really we're here today to represent the CAFC community of practice, the transition community of practice that we've been part of for the last few years. And so it's sort of an honor to be able to represent quite a great group. So let's do a quick review of what we're going to speak about today. These are the questions we hope to answer. We really believe that everybody on the line today is quite aware of the need and the importance of transitions care planning, but we'll do a quick review at Transition 101 to make sure we all have the same vocabulary. I'm going to explain to you very clearly about what a COP is and specifically what a transition COP is. So I'm going to talk about what CAFC's transition COP set out to accomplish, and then we're going to talk about what we really did accomplish. We want to talk about what's in the guideline, we're going to explain who's can, and we're going to talk about what's next, including some ideas for sharing and implementation. So let's start with the focus of transition youth. We use a very broad definition of youth with special health care needs to include any youth that requires specialized health care services for physical, developmental, and or mental health conditions. We're really looking at an age group between about 12 and 25. We know transition care planning is not exclusive to youth with special healthcare needs because transitions occur at all points in the healthcare trajectory for Canadians. Nonetheless, we argue that transition care can be particularly complex and challenging for young people. As they're part of a developmental period where there are certainly a number of additional risks, psychosocial difficulties as well. And we know that the complexity involved in transitioning from pediatric to adult healthcare places a higher burden on families and can really reduce or have an influence on an individual's quality of life and their healthcare outcomes. Transfer. We know it's important, and we know it's no news to anyone on this line that the transfer is a one-time event that will happen whether or not transition planning is done. What's key to remember in here is that we're talking about a change in the environment between two systems, and only this is the one thing that's predictable between the two, between any system, that there will be a change in the environment. Probably the most widely known definition of transition is looking at it as a purposeful, planned movement of adolescents with chronic medical conditions from child-centered to adult-oriented healthcare. We believe in that model, and we add in the fact that this transition must be supported by individualized planning in the pediatric and community settings, a coordinated transfer of care, and secure attachment to the adult services. Of course, we recognize that a one-size-fits-all model for preparing youth to transfer to adult care is not possible. It does really need to be individualized, coordinated, and collaborative. And finally, when we're talking about attachment, we're really referring to what we think is one of the important outcomes of transition practices. And this is about establishing and forming relationships following the transfer of care to adult specialists or new care providers. And so when you review any of the research literature or practice models in the area of transition, it's often concluded there's no one framework or exhaustive way to define and identify transition practices where a positive outcome occurs. But we're at a point where we've accumulated a lot of quantitative, qualitative data. Ultimately, the conclusion is that we need to make transition care planning an achievable priority. So what exactly is a community of practice? They've often been defined as a type of informal learning organization, according to Wagner's concept. They're established in order to address a certain issue and bring together people from different backgrounds and professions. These people share concerns, problems, and a passion about a specific issue. And I want you to remember that word passion as it will come up again. This definition captures three core elements of COPs. Domain, there has to be a common concern. A community, people who care about this domain. And practice, where there's a mutual engagement of community members in the activity or domain. To summarize, a COP is really an innovative model that's going to align interprofessional learning processes and knowledge translation. And it really can be designed to frame a network for decision-making and planning, and that's essentially how we used it. So what is a transition COP? CAPC's Transition COP is a collection of stakeholders from across Canada, and it includes frontline clinicians, allied health professionals, researchers, and administrators from both adult and pediatric settings, from all levels of care, home care, rehabilitation, community and tertiary hospitals, and families and youth in transition. And the common domain is that we all want to improve and support the transitions of Canadian youth. So what does this really mean? What does it really look like? I'm going to quickly flash through what I believe the CAPC's Transition Community Practice looks like. Here we go. That was just a quick review of the number of different organizations that have committed individuals to this community of practice. So, back in 2002, in response to a report from the American Academy of Pediatrics, it was concluded that after nearly a decade of effort in this field, there still wasn't widespread implementation of health transition supports as part of a basic standard of care. And CAPC underwent a process to really change this, to develop national Canadian guidelines to influence transitioning at the person and clinical level that will prompt change over time to the system level, to ensure that all youth and their families had access to supportive processes for transitioning from pediatric to adult health services, and to ensure that healthcare providers have the tools and training necessary to support families and youth in this transition process. While, of course, the scope of CAPC's practice was within the healthcare system, there was an understanding that it was necessary to include and ultimately one day make provisions for the other systems involved in a successful transition, including education, housing, social services, and I really do believe we'll be there one day. So what did we accomplish? I think, of course, one of our greatest accomplishments was a guideline for transition from pediatric to adult healthcare for youth with special healthcare needs, a national approach. Expected release date, June 2016. It's just around the corner, and we'll actually spend the rest of this talk reviewing the guidelines and some of the next steps. But before I do that, I really want to stress some of the other accomplishments of CAPC's Transition COP. We became a growing community. From 2012, we went from 30 to over 200 members, and we still are aiming for more and more national representation. We accomplished an ongoing commitment from CAPC demonstrating transitions as a priority. As a side piece, I can't quite tell what CAPC signed on for by supporting the COP, but they have been behind this model right from the beginning for the past 4 years. And it's a big thanks to Lisa Strongquist, who's the coordinator for us from CAPC. She's essentially our mother hen that keeps us on track and provides all the support. We know that we couldn't do it without her. And I think having this be a priority for CAPC is what allows, certainly an accomplishment that we've moved forward on as well. We have a collection of mutually engaged and motivated individuals. We have monthly calls with high attendance. We have a number of subgroups and working groups, one of which really focuses on developing the guidelines. And we have multi-directional dynamic information sharing process. Thanks to Ken and thanks to the individuals who take information from their organizations, bring it back to our community practice, and of course have it go the other way as well. And finally, what we have is the momentum to stay on track. And once again, thanks to Lisa for this. Oh, just to go back for a second. You know, in addition to our guidelines, as I said, these are a number of our accomplishments, but you don't have to take my word for it. This is what our members say. Being a part of CAPC's Transition Community Practice has been an enriching and a rewarding experience for me. It has brought together healthcare professionals, youth, and families from across the country who are passionate about improving the transition from pediatric to adult services, and they're learning from each other. Sharing information and resources and working together toward a common goal has united us in spite of our diverse backgrounds and experience. I'm excited about the next phase of this collaborative work. Thanks, Deb, for sharing that information. Gail tells us, in addition to that, the Transition COP became a group of friends working towards a common goal. The narratives of lived life experiences, as well as the scientific articles, informed our journey together. Adrian, one of our adult partners, said for busy healthcare professionals, it's so easy to get focused on one's own clinical population, the age group as well as the health challenge. For me, that's adults with congenital heart disease. However, a comprehensive approach to understanding improving transition outcomes across Canada requires collaboration between pediatric and adult providers and across healthcare disciplines. It has been a tremendous privilege to learn from my pediatric colleagues and contribute to this important endeavor. And finally, from Lisa. CAPC went into this with the goal to develop national guidelines for transition to adult healthcare. This was a huge goal. The concept of community practice was new to us, but very quickly, this group of people with very different backgrounds understood and mobilized. The experience over the last years has been both positive and motivating. We've come out of the other side with guidelines and a network of incredible individuals who are committed to the youth, families, and one another. I think those quotes just really say it all, and if we were able to get quotes from many of our other members, I think they would echo the same sentiments. So, as I said, we're just weeks away from releasing our guidelines. So what can you expect from this package? I start with a brief introduction to the topic of transition to adult care and really the unique health and psychosocial needs for youth with special health care needs. We'll do a brief review of the transition support and measurement outcomes. And we've, of course, described the purpose and the scope of the guidelines, our target populations and users. We went through the history and the formulation of our recommendations and ways to access the tools to support an operation of these guidelines. And we conclude with a summary of the literature on implementation and evaluation of transition programs and the next steps in the field of transition. What will also come along with this is a full reference list that will be available online, and it includes a listing of 30-plus transition guidelines and 400 or more published articles that have been scaled and graded that were really used, and we'll have a useful synthesis of the findings available as well. So what did we actually do to achieve that? Over the last 3 years, we reviewed a number of articles, looked at the evidence associated with it, and we realized in this process that there were really 8 core domains that were important in the transition. And from that, we developed some key indicators. Originally, I think our selection included about 39. We did 2 rounds of consensus survey. Many of you who are on this call were probably part of that survey, and thank you for your commitment to that. And that resulted in 19 recommendations that were at the person, clinical, and system level. And I'll go through them while we're on the phone, or on the call. Because we are looking, it's important to know, because we are looking at the health system and not the disease or condition specific, we really hope to build recommendations that were specific enough to provide guidance on but also outline what a successful program should offer, and also be generalizable enough to be implemented in various settings. You know, all organizations' programs will work within their own unique settings, but these common principles will come out. We do really believe the most important principles fall under this category of person-centered recommendation. Transition planning must be youth-focused and family-centered. It has to be inclusive of personal choice and is adaptable to the abilities and the complexity of the youth's needs. And transition of youth and their families addresses the youth's physical, developmental, psychosocial, mental health, educational, lifestyle, cultural, and financial needs whenever possible. The next set reviews our clinical recommendations. And transition, as you can see in this number 3 here, really is part and parcel with our definition that transition for youth must be supported by individualized planning in the pediatric and community settings. It must include a coordinated transfer of care and secure attachment to adult services. Healthcare providers engage, educate, and build capacity of youth and their families regarding transition. And there's always collaborative, respectful communication between stakeholders, that's youth, families, their natural networks, community, pediatric, primary, and adult care providers, all support the flow of information and ensure safe, caring, and effective transition. All youth must have a primary care provider to support care coordination. A developmentally appropriate individualized transition plan is prepared and documented in collaboration with the youth and family. Pediatric and primary providers assess the youth's readiness for adult care and must identify gaps in skills and knowledge requiring intervention. Healthcare providers and family members support youth at their appropriate developmental level to understand their chronic condition, their treatment plan, and their level of self-management. Care providers educate the youth and family about transfer of care at least once a year, one time a year prior to transfer, encouraging them to share in the responsibility of accessing community and adult services, and if needed, provide additional navigational support. And priority for care coordination is given to youth with complex needs in their families. Each transferring program is responsible to provide a comprehensive health summary at the time of referral to the adult health care providers, primary care providers, and again to the youth and family. Transfer of care to adult services includes monitoring of youth attachment to adult services, attendance at adult appointments in an expected time frame, ongoing communication between pediatric, primary, and adult care providers, and shared responsibility for management of youth with lapses in care. And finally, our remaining recommendations have to do with this system. Here are some things that are really important. All services must have a written policy for the provision of transition. All services must develop efficient and accredited health information systems to support transfer of information and collaborative communication among sectors. Organizations must designate transition champions within their pediatric and adult settings to facilitate and evaluate transition. And organizations must provide ongoing transition education, training, and knowledge translation for all stakeholders. Finally, research and clinicians develop a method for consistent data collection at an individual and systems level, including qualitative narratives of lived experiences and quantitative data that is to be used by clinical teams, decision makers, and researchers for quality improvement and evidence-based practices. We must involve youth, young adults, and families, policy decision makers, administrators, researchers, and government agencies should jointly identify system barriers, system enablers, and future developmental opportunities for the responsible transitioning of youth. And I said earlier how there were 8 domains that we really worked under, and these are those 8 domains. We're talking about implementing tools, principles, practices, supports that are youth-focused and family-centered. It requires an engagement of networks that include youth, family, and their support. There must be documentation and process changes, and there must be a plan for ongoing education, building capacity of all stakeholders. As we noted, we're really believing there's an importance of attachment to adult services. Roles and care coordination must be a big part of this, service planning and system changes, as well as evaluation strategies. And we really do believe our 19 recommendations fall under each of these categories in different ways. So that's a lot to digest, of course, in a few minutes. And so, of course, as we keep alluding to, the recommendations, the guideline will be out soon. But we're going to spend a little bit of time on the call right now to really talk about what these recommendations might look like in action. Many people on the call right now really have been the transition champions in their organizations and in their work, or even as in their families for a number of years. And so we're really talking about having a national framework. This is what CAPC is providing for us with this transition community practice. So I'm going to pass things over to John Greenaway, who's going to talk about how he's been putting many of these transition practices back. Here we go.
So, hi, my name's John Greenaway. I work at a children's treatment center in Mississauga, but we have 10 sites that are all throughout Peel and Halton and the Central West region. When I started working here 15 years ago, there was about 3,000 families that we served, and now we've grown to over 15,000 families with multiple disabilities. And we went from about 125 staff 15 years ago to over 650 staff. So what I'd like to do now is kind of introduce a video that was made about 18 months ago. I have the privilege of working with a group of youth, high school youth, each month, where we get together for a couple hours and we help plan our youth groups. We have a youth drop-in where we get about 80 youth coming out on a monthly basis from all different regions that we serve. And we also have some dances and a talent night. This group of youth, we were given an initiative from the provincial advocate, and it was called I Have Something to Say. This is what our group came up with as our submission to the provincial advocate's office.
We have something to say.
I want to be respected.
I want to be happy.
I have a voice because I'm helpful.
I want a future of equality.
I have a voice because I have to listen to people.
I have a voice because I'm young, included.
Excited.
Community.
Freedom.
I have strength.
I am confident.
We are determined to make it better tomorrow.
Courage.
I want to be acknowledged by other people.
Much for making that happen, Doug. That video really speaks to me when we look at being person-centered and family-centered with respect to working with families. The kids really, the youth, they help construct what and how I work at Erin Oak Kids. We do a number of workshops, transition to adult community, transitioning to high school. And what I do is when I'm doing those workshops, I ask a youth to come and partake in that workshop and share their stories about going to high school for the first time or starting to use community services. The next slide is developing a transition plan. I came across this slide a number of years ago from Dr. Robert Gibson and Dr. Reese, who do a lot of work in the area of transition. It really speaks to me. Within my role at Erin Oak, I work with families who have a lot of stressors on them. And when they come into my office and tell their stories, they all feel that where do we go? Who do we connect with different services? So when I saw this slide, I thought it really spoke to kind of checking out and transition planning. What I'd like to do for the next slide is what I've done is I've put a few of the recommendations on the slide that I want to speak to as I'm going through some examples within the work that we do here at Erin Oak Kids. A majority of my time is spent doing consultations with families, and I do it 3 different ways. I do it individually, where I meet with probably 200 to 225 families a year individually. And when I meet with families, we look at different pathways moving forward and different resources that are in the adult community moving forward. The next way I work is I work with our nurse, which we prioritize clients who have high medical needs and who are medically complex. And we see about 3 of those clients each month. And what we do is we deal with issues such as transferring to future medical services, connecting to adult service providers, and learning about future expectations of the adult disabled community. What we've done, and within the recommendations, and I know you haven't received them all yet, but we use a checklist that we've developed from different provinces that have different checklists. And what we've done is we've customized a checklist ourselves, looking at different resources. And what we do is we go through that checklist, and it takes about 60 to 90 minutes, depending on the family. And at the end of it, we put a 2-page report with recommendations going forward. So we try to prioritize kind of those complex clients. Within my individual consultation, what I've done, when I first started working here, I was meeting with youth who were 16, 17, 18 years old, imminently graduating school or looking towards the future and moving forward. Now I'm meeting with families now when their kids are transitioning into high school and looking at kind of the pathways, what their school records say, and looking at what they're going to be taking in school so that we can work collectively in building the skills needed going through the pathway of school and looking at the pathways of where they're going to go in the adult community later on. and introducing resources so that within Ontario, accessing developmental services, you're able to do a referral at the age of 16. But letting a family know earlier at the age of 12, 13 can help reduce some of that anxiety. And also applying for adult money later on. So it's doing that initial talk to let them know about what the future holds. The next slide is the system recommendations. So within Erin Oak, within my role, I would be considered that transition champion. And what the COPM gives to me is a feeling of not being alone. But also what I've done is I've partnered with different clinicians within our organization to be able to get that transition information out there to families. So even within the organization, I'm not alone because of that passion that I've heard so many of my colleagues talk about across the country. And it's spreading that passion within the organization, which is infectious, which helps kind of get my message out there. The other example I'd like to give about being a transition champion is that in the last couple of years, I've been put on what we call our clinical services committee. That's where we have the whole organization from admission to discharge represented on that committee. So it's another way of me being passionate and infectious with the leaders within the different diagnostic groups that are represented at those meetings. The other system recommendation, what I put here, we have a tri-ministry initiative within Ontario that's within the school boards, but it also is a way of linking community service providers in helping doing that planning for students within schools. Also, in 2013, the Canadian Foundation for Healthcare came out with a paper and literature for transitions, as well as the Provincial Council for Maternal Health and Child Health have a report, and that's online. And a lot of the recommendations that were in that report, we've blended within our guidelines. Looking forward, Erin Oak we're going through a huge transition. As you can see from the slide, we have 10 sites. In the next year, we're going to be building 3 state-of-the-art sites that we're going to be moving into. And my goal is to work within those 3 sites to embed a transitions framework for the organization. So I don't want to take any more time, because I know I have other colleagues on the phone who can probably share about their programs just as well. So thank you for giving me the time to share a bit about the work that we're doing here at Erin Oak Kids.
Thank you, John. Thank you for that lovely job of really inspiring us on how to be infectious in our organizations and passionate, and really thinking about how we're going to be doing some better and more, potentially, implementation of practices. So we'll spend the remainder of this talk reviewing a little bit more about what's in our guidelines when it comes to the implementation and evaluation of transition programs. We really do want to motivate readers and users of this guideline. So we've done a quick summary of the current state of affairs in the transitions world, focusing on key reviews, and actually even focusing on the challenges experienced when conducting research as it relates to transition outcomes. And we've outlined some newly emerging frameworks. One of the things we would really suggest is a conceptual framework for implementation of the recommendations. And it may be something like the Plan, Do, Study Act. The RNAO guidelines, I believe, includes this, and then this type of information is readily available. And we may also we do also really encourage building upon our American counterparts in the GOT transitions world. We all are probably very familiar with the 6 core elements for healthcare transition that GOT transitions has been supporting. And what's really valuable in this is including measurement tools, which includes the healthcare transition process measurement, as well as the current assessment of healthcare transition activities. And while we won't dictate what particular sort of model to use in terms of implementation, every organization knows what would work best for them. We really do believe a conceptual framework to look at changes over time are important. And certainly when it comes to measurement, we're really talking about potential new models for measurement. The Triple Aim framework from the Institute of Health really looks at the experience of care, population health, and the cost of care. And we can think about how that applies to the transitions world. The ICF, International Classification of Function, Disability, and Health, really thinks about a move beyond the health condition and really focusing on the person's function and activities in society and recognizing that they're dynamically influenced. And these efforts working in this domain is actually what's also going to help our transition planning. We keep alluding to Ken and the importance of Ken. Throughout the process of developing guidelines, and as we grew in CAPC, we were really committed to our plan for collaboration, ongoing commitment to knowledge exchange. We took advantage of Ken in many ways. All of our monthly presentations, sharing of articles, education videos, we've done our best to put this within our Ken. And here what's also really important is over time we're going to have a living document supporting our guideline document. And this is where it will include a repository of tools, and it may be including information from how to assess self-management into your practice, to clinics, checklists, as John has described, to what health summary might be suitable to your population. We don't want our partners, including ourselves, to do any reinventing of the wheel. There's great work out there. Let's really think about how we can use this to put those 19 recommendations into play. So what comes next? We really want you all to watch the launch of the guideline document and then really help spread the word within your organization. And this includes shouting from rooftops, hosting a launch party, tweeting, Snapchatting, Instagramming, whatever you're familiar with and comfortable with. Maybe it's lunch and learns with local stakeholders. Maybe it's changing your tagline on your email signature, reminding people to check things out. Maybe it's spamming all your friends. I don't think CAPC actually supports spamming, but we really want to spread the word that this is available nationally. We encourage everybody on the line, if you haven't already, to introduce yourself to Ken, get signed up, and also introduce yourself to Lisa. Really consider joining CAPC's Transition COP. Our work is not done. We are continually looking for new representation, especially representation from youth, families, and adult providers from across Canada. And the next steps really talk about, we want to talk about and we want to support a plan for improvement of transition practices, implementation, and really think about the next generation of research in your future. Thank you all for your attention, and we'll move into our question stage.
All right, thank you very much, Kush and John. A great presentation, great overview of where the community of practice has gone, the recommendations, and a little bit of a nice bit of information about what's happening both at your center, John, and the rest of the transition community around the world. So it's a great opportunity for everyone in the audience now to start typing in your questions. We do have a few in the list, but I wanted to, check if Deborah Toole is out there in the audience. I don't see her on the panel, but I'm not sure if she's dialed in my phone, and we just can't see. And getting a bit of echo from you, John. I just want to check, Deborah, if you're out there, just and you're in the audience and not on the panel, just send us type something into the question box, and we'll make sure we add you to the panel. But we do have Dr. Gail Andrew from the Glenrose. So, Gail, if you had anything that you would like to add at this point, just any sort of real exciting pieces that may have been missed by Kush and John as they went through their presentations, is there anything you'd like to add before we go into the question period?
Oh. I want to thank both of them for their excellent presentation. Trying to summarize almost 2 years' worth of work in that short period of time is amazing. And I think they've really covered everything. One of the things that, learnings that I've had is we were able to share an extensive review of the literature together. We were also, during the process, all the various presentations from really good existing models of transition across Canada. We've been able to learn from past experiences of all those different organizations. I'm thinking of the Well On Your Way program that Deb Toole is leading at Alberta Children's Hospital in Calgary, and the Toronto programs, the programs in BC led by Mary Paoni. It's just been the sharing of information so that we haven't invented a new wheel. We have just been able to pull in the best suggestions from people who already have good transition experience. And I think the moving forward, that the guidelines, they're designed to inform care based on current evidence and practice. And I think what we would like to do is also get feedback from people who pick up the guidelines and look at them within their own organization. How am I going to implement in my own organization? And at the bigger systems level, could transition, to do it well, we need devoted funding, policy change. Can this be part of Accreditation Canada? We need, many of our transition programs require navigators, having a designated position and funding to support that. So I think we have a lot of work to do at individual organizational levels, but then broadly at provincial policy and putting the funding in place. So those are just a couple of other thoughts I had.
All right, thank you very much. So the one question that did come in, John, during your presentation, Sandra was just asking, you mentioned children with complex medical needs. She was wondering what your definition of complex needs was, or if you have a standard definition for that.
We've internally developed a matrix of looking at physical and cognitive needs. So I would describe a complex need is someone who has a developmental disability, who may have numerous diagnostic services at Sick Kids or at Bloorview. They would use an assistive device, so like a manual wheelchair. Is there anything else? I have my nurse sitting right beside me. So is there anything else I've... Physical necessities. Yeah, the very high physical needs as well as a lot of cognitive needs as well.
This question is one of the things I can add, within our CAPC guideline, our transition guideline, we have included glossary terms, and we really think about children and youth medical complexity as being the children that have a unique combination of substantial family identified service needs, characteristics of chronic and severe conditions, functional limitations, and what we've used sort of Cohen and Al's definition of extraordinarily high healthcare use.
At scale here, I'm a member of another a Google group actually on complex care. Most of the members are out of the States, and this is currently a very it's this week's discussion point about developing a consensus of how to define complexity. So there's a lot of interest in getting a consistent definition.
Yeah, thanks for that, Gail. That's one of the things I wanted to mention. I mean, we had a question from Marie-Annie from Quebec, just wondering if any hospitals or rehab centers in Quebec are participating in the transitions group. We do have many individuals sort of participating in the background, not necessarily playing a direct leadership role. However, many of our Quebec colleagues, Dr. Hema Patel and her team at Montreal Children's, are playing a significant leadership role in one of our other communities of practice, which is on care of medically complex children, and they are working on a lot of these kinds of questions that our panelists have already mentioned around definition of complex care and services and similar approach to developing recommendations and guidelines as what the Transitions group has done, but focused more broadly on children with medically complex needs. So, and again, information all available for both communities of practice is available on the Knowledge Exchange Network. So please don't hesitate to go there and take a look. Search around for the information. You'll be able to find the slide, previous slide mentioned going to the communities and networks section, and then you'll be presented with an option to go to the various networks and communities of practice, transitions, and medically complex care, being just two of them. Brian has said he's not in healthcare per se. He is a clinical therapist in a residential treatment facility, currently sorely lacking in a transition team or plan or of any sort. He's hoping he can get a copy of the report and establish some connections to folks involved, and as possible. And of course, you will certainly be able to access all of the information from the community of practice on the Knowledge Exchange Network. But Kush, maybe just you had that list of sort of representing the diversity of participation in the community of practice. Was there anyone in there that would represent sort of a residential treatment facility that's participating currently?
That's a really good question. I think at different points along the way we've had input from a number of different sites. I think actually I'll kind of pass this back to Lisa for a second. Lisa will have a better knowledge of where people's backgrounds were specifically. And I'll tell you the reason for that is part and parcel when we started working on whether it was a guideline document, whether it was a transitions coordinated group, I think many of us forgot what our professions were and where we came from. We were just this passionate group of individuals who were interested in youth and interested in transitions. And so it's hard to remember, oh, are you from the rehabilitation hospital, such as Gale, or are you from the other hospital or the other home care residence, for example? But Lisa, you've got something at your fingertips that you can share. If not, Brian, come join us. Let's kind of make that connection.
All right. Sorry, go ahead, John.
And just to piggyback on Kirsch, one of the things that what we need more, I would see in our community of practice is more transition champions from the adult sector. One thing that was consistent when we met is that we see a lot of transition champions within the pediatric sector, but there's not as many within the adult sector. So I see that as a need.
Anne has asked, or she's stating that many hospitals may have developed transition readiness checklists. And she's asking if anyone can comment on how those are actually used. Who is primarily using a checklist as part of their transition program? Kush, maybe we can start with you. I think you do have one as part of the Good to Go program. There's a checklist involved.
Yes, sorry. So yes, so we had a sort of a modified version of a checklist that we've been using for a number of years. But as a side piece, given the great validated scales that are coming out, one of which is the Transition Q, and the other one is Am I on Track by the BC Children's On Track program. That being aside, the way we've used readiness checklists is multiple ways. One of which is within our own transition clinic. When we work directly with patients, we use that to sort of guide our intervention plans. We also make it readily available within the electronic patient chart so that individuals from different clinics can take a look at that checklist and see where a young person might be at. And we do a lot of encouraging of healthcare providers and their home groups to consider and think about using these checklists at certain time points along the way in the trajectory for a young patient. So maybe it's introducing it to them for the first time at around 12 or 14 to help guide how to triage patients in terms of their transition planning. Young people who have good and normally developing self-management skills, that's great. Maybe they require less help versus others who might have identified some real gaps in knowledge or skills, then that might help direct who to spend the most time on. So that's one of the ways we've used it at Sick Kids. We have really tried to make it be, you know, we've developed one that's sort of a Sick Kids tool, but we wanted it to be something that any healthcare provider could pick up and use, or the patient and family directly. We have it available on our website because we want young people also to look at it and go, oh yeah, I think I could do that, or I do that really well. Here's some other things I could keep working on.
Do you guys use a checklist as part of your program?
This is John. I can comment that we use a checklist for our higher needs, our medically complex one. It's quite a comprehensive checklist that we use. And then what we do is the same as what Krush was saying. We post it on our medical records so that all the clinics can see where the client is at and what goals we're working on for the future. So we use it internally. And we've shared it with many different organizations.
And as Gail, just one comment. Important to get the voice of youth. Their opinion, was the checklist valuable to them in their transition journey? And that's recently was done by Dr. Gortner from TanChild to compare two of the tools using the opinions of youth, because they're the consumers. We need their feedback, probably through technology.
All right, I think we might have Deborah Toole from Alberta Children's joining us on the line. Deborah, can you hear us, or can you just see if we can hear you?
Yeah, I'm here. Can you hear me? I hear you.
Yeah, we can hear you. Welcome to the call. Anything you'd like to add at this point?
Well, I think like everybody else, we've developed readiness checklists and tools. I think one of the things that we find the most valuable is put them online so patients and families have access to them, and then they can be working on those skills at any point. And I think, as Gail said, it really needs to be youth-directed, and they need to be valuable to the youth.
All right, thank you very much. And we can hear you. You got a little bit quiet near the end, so just make sure you're nice and close to the phone so that we don't miss anything that you're saying there. The next question was about, I can't remember if it was Kush or John who mentioned, I think it was John, you were talking about the collaboration between the ministries, the PCMCH, the education and health ministries, etc. She's saying it's wonderful to provide family-centered care. She says it's not the case in Quebec, and she's asking any suggestions on how to make that happen. Do you know, are you familiar with any of the background that led to that collaboration or facilitated it, or any background on that?
I was approached or nominated to be a part of that committee. It happened through the LINS, which are our local health integrated network, who kind of, I think, or no, it didn't happen through them. You had to be a part of a LIN, and you had to be nominated from the region because they represented all of Ontario. But no, I'm not sure. But talking about community partnerships and how to develop them, I know within Ontario, it's a huge push within the school boards for transition planning right now. So I know within Peel and Halton, we have two separate committees working on transition planning within those school boards. And what it's done is brought healthcare providers as well as developmental providers as well as educational providers together, sitting at the same table and trying to develop a common language to speak when we're transition planning. Because sometimes within education, health doesn't know what's going on, or health has a different language from education or the developmental community. So it's having some of those initial discussions right now.
All right, thank you, John. Gail or Deborah, is there anything similar to that happening in Alberta as far as a provincial approach that's taking a cross-ministerial sort of approach to transitions, engaging multiple stakeholders and sectors, et cetera?
Do you want to speak to that, Gail?
Because we have a single health service across the province, Alberta Health Services, there is a network, maternal, neonatal, infant, child, youth network that has got a transition topic and a group working towards more of a pan-Alberta approach. And I think because Deb has taken such leadership in the work that she's done with Well On Your Way, many of the elements of Well On Your Way would be appropriate to look at as a pan-Alberta approach. It's predominantly a health-based network at this point, but recognizing that we need to involve all stakeholders, including education, housing. In Alberta, we have disability supports, which services family supports children with disabilities from a young age through to youth, and then it transitions to persons with developmental disabilities when it's in the same office. So bringing all the important sectors at the table. So we're at that point, we're having some meetings, discussions, and then moving forward.
Yeah, this is Deb. I would add to what Gail is saying that it's really early days in terms of the provincial initiative, but yeah, the focus of bringing, not just health, but other ministries that are, focusing on transition into the picture as well, I think is important.
And I think as in every place who goes into transitions work, involving the adult healthcare providers is critical. And talking about having a primary healthcare provider for any young child who has a complex condition and having that child then transition as a youth and adult with that same health provider, that's really important because that health provider can do some of the functions of case coordination. But as pediatricians who work in, such as myself, in a rehabilitation facility, we have an understanding of how these complex conditions evolve through from early childhood to youth and then transition needs. Many of our primary healthcare providers don't receive the same level of training because, quite frankly, they're supposed to be experts at everything. So I think we really have a role as pediatricians to continue to mentor and support our primary healthcare providers, and also perhaps developing more of a shared management approach at that transition or the transfer point, where we are available to provide information to the adult healthcare provider about our patients' needs. So I think we really have to get engaged more with primary healthcare providers and adult subspecialty services to make this transition work.
All right, thank you very much, Gail. The next comment's coming in from Yanni. First, she says, "Hi, John and Kush. It's Yanni at the Center for Addiction in Mental Health in Toronto." And with that, I want to say thanks to Dr. Amaria. She did have to quietly sneak off in the background right at noon here, so I think she's already left the panel. But I did want to thank her before she left for such a great presentation. But Yanni's saying that since these are national guidelines, how do you foresee mobilizing the guidelines within provinces, since health and other sectors are funded and administered by provincial ministries? What are the challenges or opportunities for advocating for policy change nationally or provincially? John, maybe we can start with you, since Dr. Amaria has left us, and we'll put the weight on your shoulders to take this one, to start this one, and then maybe we can hear from Deborah and Gail as well.
Because we've briefly talked in our COPM about that and how to strategically go about doing that, but that's a very difficult one. I would rather Gail tackle that one first.
Yeah, Lisa Stromquist, the national coordinator for the program, wanted to make a comment here. So, Lisa.
So one of the strengths of CAFC is sort of our national breadth and the scope and our partnerships with other national organizations like Accreditation Canada. So we have been in discussions with Accreditation Canada, and recently they have included some more medicine standards that are related to transfers of care and then leading into transition. So I think that as we work more closely over the next few years with Accreditation Canada and with our children's hospitals and with our transition programs, we'll be able to maybe influence some more of those national standards that become accreditation standards. So I think that's probably our best strategy for making this for this national approach.
Doug and Lisa, can I just pop in there for a second as well?
Yeah, go ahead.
Thanks. I really, really support. First of all, it's a great question in terms of how do we mobilize guidelines provincially? And Lisa just hit the answer bang on. I think that has been CAFC's strategy for the last decade or so, and we've been able to demonstrate the ability to impact provincially through our national partners, like Accreditation Canada, or another example is some of the work we do with the Canadian Institute for Health Information. So we totally respect the provincial jurisdictions, and as Dr. Amaria said right at the beginning of this presentation, never does one size fit all. But at the same time, because our strategic partnerships are primarily at a national level, we are able to impact provincially because of those relationships, and we've demonstrated success in other areas. So, to Lisa's point, that is what we feel to be the best strategy. I just wonder if there's any thoughts.
It's Gail here. I think Accreditation Canada, we've had some sessions during our community practice on increasing involvement. But I think what we have a responsibility for is to get the data as we, and we do have some good transition programs across Canada, to look at the data and using the approach that Kush mentioned with looking at the triple aim, where we're looking at improving the health of the population, we're looking at improving the care experience of the individual and their caregivers, and the cost. Because if you look through the literature, it is costs up front to develop a good transition program, but the saving ultimately to the health system is considerable if you look longer term, as well as the hard to measure, but the quality of life of that individual and their caregivers. So I think we have to get the data and continue to follow our data longitudinally to be able to talk to people to influence policy.
All right, thank you, Gail. And Elaine. The next question is from Scott at the Glenrose. He's saying, I noticed our definition of transition is focused on transfer of health care. However, we all know that there are many transitions that affect youth. Issues such as housing, education, employment, finances can all be further compounded by a chronic health condition or disability. While it's reasonable to focus this work to healthcare, he's wondering if we should make reference to the big picture as a preamble and then drill it down. Was there any discussion about this as the guidelines were being developed or the work of the community of practice? I mean, I know earlier in this presentation and throughout we've sort of commented on the multi-sectoral sort of needs of children. But was there any conversation about that as this was being developed? John, I think it sounds like you've got something to say.
Oh, yeah, I just took my phone off mute. That was a big discussion, and even when I meet families in my office, when it's solely healthcare, families are very isolated. However, when we look at the community at large and building those adult partnerships and getting out there, and instead of going to one children's treatment center or just at sick kids, now you're going to 5 or 6 different hospitals for very different interventions. It's more complex, as Scott made note of, but as well now, instead of just going to school, you may be accessing many different community programs. So we did talk about it, but it's very important that we take a holistic approach when we do transition planning for all the different transition planners that are out there.
And as Gail here, we've had discussions at many meetings about looking at this holistic approach and moving beyond just the health system, because Scott's right, all of the systems are intertwined. And Kush mentioned that we used the framework of the International Classification of Function, where the health condition is one of the variables, but in order to support that individual who has a health condition or disability or a mental health condition to reach optimal participation in life. You have to consider all the environmental factors as well as the personal factors, and that involves all of the things that Scott brought up. So we've had many lively discussions, and if you get to read the very large document that was developed along the way, it's captured quite nicely.
Hi, this is Lisa. I just wanted to further comment that, as Gail said, we had many discussions about this, and the members of our COP were all healthcare based. So we thought that we should probably focus on the things that we knew best and that we could sort of manage or bring expertise to, with the understanding that all of these other factors are hugely important, and leaving space for all of those things to be included as we learned more and as these guidelines sort of went out into the public and went out into use. Our approach is a quality improvement approach, so we want people to use these guidelines and then tell us what happened with them, and how were you able to implement them, and how did it work, or how did it not work, and bring them back, and then they'll constantly be improved. And again, we'll be doing. Hopefully, this will sort of influence some research, as Gail has spoken about, and we'll be able to and get that important data to support the work that we want to do and the improvements that we want to make. So, thank you.
We did have a comment come in from Deb in Edmonton with Children's Home Care Services within Alberta Health Services, and she says they've been working with adult services and health and other ministries to help transition children. But it's only being done on an individual child basis at the local level. Not they've been working on developing a standard process with local partners, but not at the provincial level yet. So definitely recognition of the importance of this issue to work with multiple stakeholders on these issues, but always the challenges of working at the provincial level across those ministries. The next question, again coming in from Maria Nee, is saying, when there are multiple rehab centers or hospitals in the same area, for example, Bloorview, Sick Kids, Aronoke, etc., how do you decide who takes the lead in the transition? So this would be an issue that's largely, well, maybe not always, but in our larger centers where you have those multiple big players that all play a role with these children. How does that work in those areas? John, you being Kush having left us, maybe John, you could take this one. How does that work as far as identifying who's the lead on these?
Yeah, so I can speak from kind of how it works with that example. So at Sick Kids, it's more acute care. They're going to clinics episodically. With Bloorview, from the kids that I work with, they would go there for more of a long-term rehab. So they've had an operation, and then they're off to Bloorview for a 3 to 6 month rehab, and then they're off to home. When they come home, then that's where Aronoke kids would kick in and do that rehab while they're at home. So we would have therapists at our center as well as within the home if needed, based on what the need is. So we all have our specific roles, and we also make sure that we communicate, and that's that collaboration between services to make sure that we're not duplicating. So if there's a clinic that exists at Aronoke, that the clinic at Sick Kids knows what's going on. So we do have that dialogue. And we also have access to YSHCN, which is the Electronic Children's Health Network, where we're seeing notes that are posted at the different hospitals.
And as Gail here, I can comment about our Edmonton experience. The Glenrose Rehabilitation Hospital is a freestanding hospital focused on rehabilitation actually across the lifespan, from the neonatal clinic right through to adult geriatrics. The Stollery Children's Hospital is on the university campus site, where that's the place for acute care management of chronic health conditions as well. And we are collaborating together. We've both done our individual transition work at each center, at the Glenrose and at the Stollery, and we are now collaborating because many of the children with complex medical will also have complex developmental needs. So we want to make sure that, again, being family focused, that we collaborate together in developing the transition plan for a child who has both needs. So I think that collaboration, communication, partnerships, and so that we can do the best for the family without having 10 different people giving 10 different directions.
Thank you, Gail. We only have one more question, so if anyone else has a question and they really want to have it answered, please do type it in as quickly as you can. We'll get it into the list. But if not, then we may be wrapping up, and maybe we'll hear some closing sort of comments from our panelists, just some key messages that you think might be important to leave the audience with. But this last question I'm going to send over to you, Gail. Sheila's saying, transition issues for youth with FASD or youth who are Crown wards adds an additional level of complexity. Their parent, quote unquote, is the province. Are there models of care coordination for these youth who have complex needs? And I'm just handing it over to Dr. Andrew, because FASD is one of her areas of clinical and research interests. So Gail, do you have any thoughts on children with FASD as far as transition and care coordination?
That has been one of my favorite topics for several years. And I've actually presented, not solutions, but presented the problem with some ideas for solutions, because we aren't there yet. I can speak to my experience within the province of Alberta. A youth who is living with FASD, who is in the care system, their responsible guardian is somebody within Children's Services. And they can extend their connection with that youth up at age 21. Look at facilitating the transition needs. We may, in my particular clinic, the Glenrose FASD clinic, we spend a lot of time with each youth and their caregiver on, looking at what are the key elements of transitions for that youth. The biggest problem we have is often our youth who are with FASD are not as willing to accept the extensive support services that would be in their best interest. Don't have a lot of housing options at this point. Have some good pilot projects on housing in the province that are still in the process of being evaluated. What are the employability options? And we know that individuals living with FASD often have chronic health problems. It is a whole body condition, and to ensure that needs are met. And a lot of our individuals with FASD have significant mental health problems. Some studies report up to 90%. So transitioning within the mental health system is also extremely important. So I don't have a solution. We do have, at our provincial level, we do have a cross-ministries committee working on all aspects of FASD as a lifespan condition with chronic health issues. So I don't have solutions yet, but I think over the next few years, we're looking at these pilots. We might be able to have the data to support how we should be doing a better job. We have a youth program here in the Edmonton area called the McDaniel Youth Program, and that to me has shown some nice promising practices. It's mentorship, so a youth from 16 on is given a mentor who will work with them over a period of 3 years, and a lot of the mentors' work is around transitions to help support that young person. And the mentorship works because it's a positive relationship-based intervention. So again, it's still under evaluation, but I think a lot of our youth who are, especially in group care, they don't have one individual who they trust sufficiently to help them through this transition process. So I think over the next few years we'll have more data.
It would always be helpful, but such a challenging issue for sure. So with that, there are no more questions, so we're just going to go around. Maybe we'll go in. Well, actually, one did come in just as I was about to say that. Yanni's just saying, she's asking about the guidelines. She's saying, do the guidelines incorporate ideas of a life course or lifespan approach? although the transfer from pediatric to adult healthcare is very important, what happens down the road, particularly as parents or / family caregivers may become less involved as the adult ages? What else do we need to do in addition to seeking adult partners at the point of transfer? So John, maybe we'll go back to you, or John, or Deborah, since we haven't heard from either of you in a bit. Any thoughts on that?
That's a great question. That really is a great question, because it was making me think that we're having, or some of the things that we've seen in the last 5 years here is that we're having more youth with medical complexity live longer. And as they live longer, their parents are aging. And it's a huge concern. Wills and estate planning have been more of a hot topic, whereas when I first came here, it wasn't. So it's a very good question, and I can't say I've been in that many discussions about it, but I know when I'm talking to adult service providers, it's really a hot topic. Even when on our referral to adult developmental community, they're asking specifically for the age of the guardians, knowing that is of high risk and of great concern.
Perspective of the Well On Your Way program at Alberta Children's, any thoughts on that?
I was just going to echo what John was saying, that it is a very complex issue, and I think it goes back to the question that we had earlier, that we really need to take a holistic approach to transition planning, and the whole lifespan piece is also important. As caregivers are aging out with some of these, especially the medically complex young adults. And I think that also, speaks to what Gail had talked about with the FASD population. There's lots of work that needs to be done around housing and care, long-term care, appropriate resources. And I think it's on the radar. We just aren't there yet. And I know provincially we are working at some cross-ministerial stuff to address that with disability services and Alberta Health Services recognizing that we need to get there. So there's a committee here in Calgary called the Calgary Complex Needs Cross-Ministry Committee, and a lot of those young adults, your FASD population, your autism spectrum, those that with complex medical needs, complex conditions, those who are getting older with, comorbidities, mental health. Those people come to that committee, and there's different ministries represented where we talk about, okay, how can we address this person's complex needs? And it isn't just during transition. This committee is now across the lifespan. So there's some 40-year-olds that are coming to that table as well. So I think it's on everybody's radar. It's we haven't got any great solutions yet, but recognizing that we certainly need to move towards that a lifespan approach as well.
And in scale our experience here at the Glenrose, we have stepped forward, not stepped back, or stepped forward to look at all our services should really be a lifespan approach. And we're beginning right now with the population with autism. We've been able to, with multiple partnerships, develop an adult-focused clinic for involving actually the mental health team as well as autism experts, and then experts in things such as community participation, employability options. So we're just at the beginning of this development, and hopefully be able to expand the concept to other disability populations.
Very much to everyone. That was a great conversation. I mean, I think Deborah, you hit the nail on the head when you said it's on people's radar. I mean, I know our rehab community talks about the lifespan approach and our complex care community of practice, et cetera, but it's still something that people are struggling with, trying to really implement that fully in all aspects. So I think we're going to wrap it up here. We're just about out of time. We've exhausted the list of questions and perhaps even exhausted our presenters. So we'll wrap this up. We're just going to go around the table one more time, and maybe we'll start with the order that we came in on. John, we'll start with you, and just get anything that you'd like to close the audience off with, or any thoughts around sort of key messages that you think might be important for them to take away from this.
So I've written 4 things down. Very quickly, I'll go through them. What would be most important is start early. On admission, introduce the family that they're going to be discharged from your service if you're a pediatric provider. That's what I mean about starting early. It's getting families in the frame of mind that they're not going to be in the service for the whole their whole life of their child. Building skills was my next one. Youth and families, we need to listen to them and build the skills that they need to be able to enter into the adult providers, whatever they may be. My third point would be collaborate with our partners, whoever they are pediatrically and whoever they are in the adult world. And then the last point, which is listen. We need to listen to our families, and we need to listen to our youth, and we need to value what they say.
Great comments, and that whole piece about listening to the youth. We'll make sure we get a better copy of that video for the recording. It'll be a much more clear copy, so you can hear the voices of those youth and their question about are we listening to them. So maybe we'll go to Gail. We'll go to you next. Anything you'd like to leave the audience with?
I think we have a responsibility to continue to talk about transitions and become advocates for at all levels, from involving the individual primary health care providers in this journey right up to the policy people, and often just keeping the momentum going, because I think we are going to be able to push this forward.
Deborah, anything from you before we hand it over to Lisa for the final comment?
And I would echo what John and Gail have said. I think the points that John made for sure are huge, and I think continuing to raise awareness of the importance of doing a better job of transition. I think the thing that comes, an additional thing that comes to mind for me is the importance, as Gail mentioned earlier, of data collection and research. And I think, the really wonderful thing about the community of practice is the relationships that were forged, and the recognition that we can't do this alone and in silos. We need to work collaboratively. And so I think even in terms of gathering data, and good data that says what works and what doesn't work. So I would kind of throw in the importance of research moving forward.
Over to you, Lisa, for the last word.
Right. I just want to thank Kush and John and Deb and Gail. They're representing a group of about 180 individuals that are from around 60 different organizations. So they're a few of the leaders of this very large network. And I want to just talk a bit about the strength of the network and how all of this work is only possible, just like Deb just said, it's through the collaboration of all of these different groups, everybody bringing their own experience and their own expertise to the table. And everybody's transition issues are pretty similar across the country, but everybody's experience is slightly different. So it's great that everybody's able to share. And I think that some of the questions that were raised today that we didn't have answers for, I think those are topics for us to discuss within our community of practice, and those are things that we can work towards, again, together over the next few years. So the work is really just beginning, right? We've developed some guidelines, we've got through this piece of it, and there's still a lot more to do, and I think there's a lot of enthusiasm across the country. So it's a big thank you to all of the individuals and organizations who supported this work.
All right, thank you, Lisa. That's a great way to wrap this up. Like she said, there's a really significant network, large number of people all contributing to this work, and we just want to thank every one of them for their contributions. So with that, I think we will wrap up. We do want to just mention one more time, the Knowledge Exchange Network is the place to find more information at ken.cafc.org, ken.cafc.org. All of this information you can find there. Contact information for Lisa if you're interested in becoming a part of the community of practice or becoming more involved in the community of practice. Lisa is definitely the person to talk to, and she can get you all hooked up with that. So we do hope to hear from everyone soon about this work if you are interested in getting more involved. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great when you can watch live, as the discussion is really the best part of the whole presentation, to hear your thoughts as a community and interacting with the experts. But when you can't watch live, as I mentioned at the beginning, we do record these sessions and make them available after the fact on the Knowledge Exchange Network. Next week, we're going to be hearing Dr. Kim Widger and Dr. Adam Rappaport from the Hospital for Sick Children in Toronto about an epic, in quotes, journey across Canada to improve palliative care for children with cancer. An EPIC, EPEC, standing for Education in Palliative and End-of-Life Care. It's part of a larger national project funded by the Canadian Partnership Against Cancer to enhance provision of palliative care services. They assess the quality of palliative care provided to children with cancer and their families, and in this session they're going to provide an overview of what's going well, and as well as areas for improvement in palliative care currently provided for children with cancer, and then hopefully taking all of those concepts and translating them across to improve palliative care services for all children. And then the week after that, we're going to be having an update from more of CAFC's work, an update on standards in interfacility transport of critically ill neonatal, pediatric, and maternal patients. During that session, we're going to hear from Kate Mann and Dr. Alan DeCon, the co-chairs of CAFC's work for the last number of years in interfacility transport, as we wrap up 8 years of work on standardizing transport knowledge and practice. And then we're going to hear from our colleagues at Accreditation Canada. Stephanie Carpenter is going to join us and talk to us about how that work has been translated into standards and embedded into the hospital accreditation program that Accreditation Canada delivers across the country. So some great stuff coming up in the next couple of weeks. Thanks again to our audience for joining us today, and a big thanks to our panelists for joining us, and we hope to see everyone back here next week. Bye.